Hello everyone. So let's start with a quick recall of anatomy question being asked for the NEET-PG 2024 examination. So let's start with the discussion of the question related. Many of the question must be correlated or explained in the other subject also, because anatomy is correlated with other and it is integrated with other clinical subjects. So all those MCQs which I have gathered, I would like to share it with you. It can be possible that the options will be different or the topic is only discussed, because exactly what was the option and what was the language of the question is exactly not framed like that, but the topic has been asked like this and these were the questions being asked. So the first MCQ is ptosis in Horner syndrome is due to the paralysis of which of the following muscle? The options are superior tarsal muscle, orbitalis, orbicularis oculi, sphincter pupillae. So here exactly, as we know that if I am talking about Horner syndrome, and in case of Horner syndrome, mainly the defect is of sympathetic innervation and the smooth muscle fibers of the part of the levator palpebral superioris is involved. Actually, I would also like to tell you about LPS muscle, because LPS muscle is having both skeleton muscle fibers and having the smooth muscle fibers. So here when we are talking about the case of Horner syndrome, when I am using the word Horner syndrome, it means the sympathetic fibers has been affected and the right answer will be Muller's muscle. So that means superior tarsal muscle is the right answer. Okay, so ptosis in Horner syndrome is occurring by which muscle, and which muscle is affected? The right answer is Muller's muscle. So actually, if I talk about a Horner syndrome, as I already told you, there must be a defect in the sympathetic pathway. So abnormalities can be ranging from mild to moderate, and exactly there you should be also knowing the difference between the complete drooping of upper eyelid and that of partial ptosis. In Horner syndrome, there is partial ptosis. So exactly if I talk about the superior tarsal muscle, it is also termed as, the other name of superior tarsal muscle is also termed as Muller muscle. So it's a structural muscle for maintaining the elevation of the upper eyelid. Actually, what is the uniqueness of LPS muscle is that it is having, if we talk, so I would like to talk about LPS muscle origin and insertion, how it divides into three laminas and what is the fibers which is constituting. So exactly if I talk about LPS muscle, levator palpebral superioris muscle, which is one of the extraocular muscle, which is exactly originating from the part of sphenoid bone. Which part of the sphenoid bone it is originating? It is originating near the surface of the lesser tubercle, so lesser wing of the sphenoid bone, and it is lying very close to optic foramen. But when it is diverging, it forms laminas, and it is actually having the insertion in the tarsal plate. So it inserts into the upper eyelid as well as superior tarsal plate, and this is made of skeleton muscle. The superior tarsal plate is actually, if we talk about the two important parts of it, the superior tarsal muscle is the Muller's muscle, which is having smooth muscle fibers. So exactly if I talk about the whole innervation, if I talk about the nerve supply of the Muller's muscle, it is from the sympathetic innervation. So that is the reason here we can see this is LPS muscle, the muscle of the extraocular muscle inserting the upper eyelid, and it also merges with the conjunctiva, superior conjunctiva, and also with the tarsal plate. So exactly the smooth muscle fiber is the superior tarsal muscle, which is called as the Muller muscle, which is affected in the condition of Horner syndrome. So why I want you to give this concept, that means complete ptosis or complete drooping of upper eyelid will happen only when the skeleton muscle fibers and that of smooth muscle fibers both are paralyzed. So that will happen when the oculomotor nerve is giving innervation to all extraocular muscles of the eye except LR6 and SO4. That means except lateral rectus muscle and superior oblique muscle. So if the sympathetic innervation is gone, causing Horner syndrome, and also the oculomotor nerve, which is innervating the skeleton muscle fibers, is not functioning, then complete ptosis will happen. But in case of Horner syndrome, only partial ptosis happens because only the Muller muscle is affected. So here the superior tarsal plate originating under the surface of LPS, inserting into the inserting into superior tarsal plate. Here you can see this levator palpebral superioris, and this is the superior tarsal plate insertion. And if you will see this view, actually this is the view where you can appreciate the entire muscle, and you can see it from the lateral aspect. You can see LPS muscle is more superiorly. So done with this, now let's move on to the next question. So here the innervation, superior tarsal muscle is innervated by superior cervical ganglion, and as I already told you, skeletal muscle fibers are innervated by oculomotor nerve. Now, one more MCQ was asked about the location of Meyntrich plexus in the case of Hirschsprung disease. Actually, Meyntrich and Misner plexus, these are the two plexus in the layers of GI tract. So, I would like to talk about both of it. Actually, the correct answer will be between the muscle layers. So, if we talk about the Meyntrich plexus, which is also called as Ayurback plexus, it is located between the circular and longitudinal muscle layer. And what is the important function of this? It regulates the peristaltic movement, and actually it is very important for the transmission of the migration of the food particles from stomach, bowels and the colon part. So exactly the location, two nerve plexus are there. One is Misner nerve plexus, which is lying in the submucosal layer of the GI tract, because when I am talking about the gastrointestinal tract, if we talk about the GI tract, as we proceed from inside to outside, we will have the four layers. We will have the mucosa layer, we will have the submucosa layer, we will have the muscle coat layer, and we will have the outer serosa or adventitia, mainly serosa. So exactly in between the muscle layers, that is muscularis externa, there is the location of Meyntrich nerve plexus. And if I am talking about the Misner nerve plexus, it lies in the submucosal layer. So here I just want to show you the schematic diagram in which you can see the location of Meyntrich nerve plexus. This is the Meyntrich nerve plexus, which is located between the longitudinal muscle coat and circular muscle coat. Now, other than that, we will have one more image where I would like to give more details. So, actually, what about the condition? Hirschsprung disease is a birth defect where the nerves are missing from the intestine, and the most prominent symptom the baby will complain is of constipation. Now here I just want everybody to understand the two nerve plexus and the general plan of GI tract. So exactly this is a question of histology. The organization of gastrointestinal tract is to be explained to you. I am just showing you general organization of GI tract. So this image is showing you the general organization of GI tract. We have got following layers as you proceed from inside to outside: the mucosa, the submucosa, the then we have got the muscularis proper, or you can say muscle layer external. So muscle layer external and the serosa or adventitia. So as you can proceed, and you can see that I told you Misner or the submucosal nerve plexus is lying in the submucosa layer, and exactly the location of Meyntrich nerve plexus is between the two layers, that is circular and muscular coat of the muscle layer. So that is the right answer. Now let's proceed to the next question. Fecal discharge from the umbilicus, what is the diagnosis? The question was like something like that, fecal discharge is from the umbilicus and you have to diagnose the case. The option provided is urachal fistula, ileal diverticulum, omphalocele, gastrochichis. So let's talk about this. So and the some students told that umbilical discharge of fecal matter, something like this was the question being framed. Maybe the option can be different, maybe the language of the question is different, but that is clear that the question about this condition has been asked, and the correct answer will be omphalocele. Let me explain it. So before starting with the case, I would like to show a few images for the understanding. I would also like to talk about the anomalies of intestinal duct. Okay, so if I talk about intestinal duct, what it is connecting? It is connecting the mid-gut loop to the yolk sac. So if we are talking about intestinal duct, it is important for you to note down that it is connecting the mid-gut loop apex to the yolk sac. So normal condition mein kya hota hai? When I am talking about the normal condition, it will disappear completely. But sometime what happens there, that this duct is not fully exactly there is not complete obliteration. Okay, there is complete obliteration is not there, and a part of it persists, and this will lead to anomalies of intestinal duct. And I would like to talk briefly about the anomalies of intestinal duct. So one of the anomaly which is commonly seen in the population is Mickel's diverticulum. So if I'm talking about Mickel's diverticulum, a part of vitelo-intestinal duct is coming close to the midgut loop, that is called ileum, and it will persist as a Mickel's diverticulum. So exactly it is connected to the umbilicus, and that connection to the umbilicus is via a fibrous cord. It's via a fibrous cord. So the obliterated remaining part of the vital intestinal duct persists. So that means how you can appreciate this, that a small part of vital intestinal duct is still persisting. It is not obliterated completely. Now a rule of two is also applied here. What you can see here, this is the, so this is three images has been shown to you. The first image is showing you about the vitalointestinal duct and how it is connecting the midgut loop to the yolk sac. The other is showing you Mickel's diverticulum, and the third one is image is showing the image after the surgery being performed. So if I slightly enlarge this, you can appreciate this. So if I am enlarging it, you can appreciate this is the yolk sac connected by vitalointestinal duct to the apex of midgut loop. Now, if a part of it is not obliterated completely, it will lead to the condition of Mickel's diverticulum. So now Mickel's diverticulum sign and features has a rule of two is applied. Actually, Mickel's diverticulum will be a small diverticulum which is located at the anti-mesenteric border. Approximate length varies. It can be 2 inches. It is present in 2% of the population. It contains the gastric mucosa and sometimes the pancreatic tissue. If there is ulceration, actually this is also asked in the previous year of examination, that Mickel's diverticulum can be can have a differential diagnosis with other condition that is called as appendicitis. So that is important for you to note down. Now, other other anomalies of vitalointestinal duct is umbilical sinus will be there when a part of vitalointestinal duct close to the umbilicus is persisting. So this is in the form of sinus. If the whole tract is there, so if we are talking about umbilicus sinus, it is communicating with the umbilicus. If the whole tract is not obliterated, it has communication internal and external. That condition is called as fistula, or a cyst can be formed in the middle part. So you can see vitalointestinal fistula, as I told you, the vitalointestinal duct fails to obliterate. It has got communication on the two ends, and it may contain the discharge particle from the umbilicus. Cyst is a small middle part of vitalointestinal duct is persisting. Now, another condition in which leakage of, or you can say discharge of urine happens from the umbilicus, that condition is called as urachal fistula. So, urachal fistula is, we know that there is a urachus which is a remnant of median umbilical ligament. Median, please note down, it is median, it is not medial. Median umbilical ligament. So, when I am talking about median umbilical ligament, this ligament is connecting the apex of the bladder with that of the umbilicus. So exactly, if it is actually what happened, if the urachal fistula is formed and that communication is not obliterated, it can lead to there is incomplete obliteration of urachus on the median umbilical fold. It can lead to the discharge of urine at the umbilicus. So that is the case. That is the case. Now, one more question about the clinic, about the embryology was Omal Seal, and I just want everybody to have a quick revision of this topic, because why it is important, I will take the other. So actually, number of questions are being asked, and exactly one of a few students has told that a covering of Omal Seal and what it contains was asked. So covering, if I talk about, amnion is the layer which is covering it. So definitely amnion will be the right answer. The covering of Omal Seal is derived from amnion layer. Now, Omal Seal is also called as oxymphalos, is a rare abdominal wall defect. Actually, what happens in this condition? The intestinal loops are pushed out. So we know that there is a condition of physiological herniation, and the intestinal loop which has not got enough space, and it will protrude out, and again it will return to the abdominal cavity, and this process is completed by 12th week. But if there is persistence and presence of abdominal structures, intestine, stomach, and or intestinal loop outside liver and all, it is called as Omal Seal, and it is a grave condition. Actually, this is a condition, this is an image which is showing you the condition of Omal Seal. So here the tumor you can see here, this is the Omal Seal. Also the umbilical cord stump is still attached, And I would like to talk about the coverings also. Another condition, I just want everybody to understand these common terms, because this has several times has been asked in previous year of examination, and this year also it has been asked. So you should have the concept of differentiation with the common correlated condition. The other condition is gastrochesis. In this condition, there is a linear defect of the anterior abdominal wall through which the abdominal content will herniate out. Okay, so exactly omphalocele means the normal return of physiological herniation of the intestinal loop doesn't happen, and gastrochesis is the condition where there is a defect in anterior abdominal wall. So it occurs lateral to the umbilicus. Usually the side will be right, and also the defect is produced when lateral fold of embryo fail to fuse with the connecting style. Now here this is the image where you can see this is a schematic diagram showing you the coverings of omphalocele. So you can see it is covered by, so it is covered by the layers. As you can see, it is having a covering of the amnion, it is having the coverings of Wharton jelly, as you can see in the diagram. So I would also like everybody to know the difference between congenital umbilical hernia and omphalocele. So herniation of bubble loop, intestinal loop, which is occurring through a normal process. Actually, normal physiological herniation is not returning. Physiological herniated loop is not returning back to the abdominal cavity, then omphalocele happens. Herniation of bubble loop occur through weak umbilical opening, and this will be the reason for congenital umbilical hernia. Other than that, if I talk about omphalocele, it is definitely having the covering of Wharton jelly, amnion and peritoneum. Here there is a covering of skin and subcutaneous tissue along with the peritoneum in case of umbilical hernia. So why we will go with the best answer? We will go with amnion as the best covering layer for omphalocele. And the bad prognosis is associated with other congenital anomalies in case of omphalocele. So it is having bad prognosis or poor prognosis. So it will have amnion and Wharton jelly covering it along with the covering of peritoneum over it, but we will choose amnion is definitely covering the omphalocele condition. So we will go with the amnion layer as the right answer. Now, I just want you to show two images where you can see the difference between omphalocele and gastrochesis conditions. Here you can see the sac protruding. Here this is the umbilical cord, covering membrane is there, and exactly you can see just slightly laterally the sac protruding and with no covering of the membrane. That is the case of gastrochesis. So exactly you can differentiate between this, and you can see the amnion layer also. Here the covering layer is also shown. So done with this. Okay, one more question of anatomy was they have asked about Broadbands area 22 and what will be the effect of lesion in this area. Okay, so what are the effect of lesion of Broadband area 22? Whether it causes the lesion of expressive aphasia, receptive aphasia, poor repetition of languages, or poor naming. So exactly, I will go with receptive aphasia, and I will tell you why. Actually, you have to know about motor speech area and sensory area, that is Wernicke's area. So the question has been asked about Wernicke's area. It is area number 22, and what is the location of this area? This is located in superior temporal gyrus of the brain. In which temporal gyrus? In superior temporal gyrus, and it is located in the left cerebral hemisphere. That means it is located in the dominant hemisphere, and most of us are right-handed, so it will be in the left cerebral hemisphere. It helps in understanding the individual word and generation of the word. So definitely the resultant loss will be of receptive aphasia. Expressive aphasia will be of the motor Broca's area being affected. So we have got Wernicke's area. Actually, it is supporting the language comprehension. Lesion with auditory cortex can lead to Wernicke's aphasia. And if we talk about Wernicke's aphasia, it is also called as, the term used is receptive aphasia. So it is a case of language disorder, in which case there is difficulty in comprehending and understanding the language. Broca's area, that is area number 44 and 45, which is located here. If I talk about Broca's area, it is located in the pars triangularis and opercularis, and actually language processing. And there is, if this there is a lesion of area number 44, 45, what will happen? We know that it is located in the pars opercularis and pars triangularis of the dominant side, that is most of us are right-handed, so it will be in the left cerebral hemisphere, and the resultant condition will be language, production of language, speech deformity, Broca's aphasia, and this condition is called as expressive aphasia. I would just like to show you this location that can be also, it is very important because they are lying close to each other. Can you see here, this is a superior temporal gyrus in which area number 22, and just above it we have got the pars triangularis and pars opercularis for the area number 44 and 45. So this is motor speech area and this is Wernicke's area. This is motor speech area, this is Wernicke's area. Sensory nerve supply of pinna. There was one question about the sensory nerve supply of pinna. So what I want, actually with an option the question has been framed and we have to find out the correct auricular nerve supply. So 4 options are there here. Actually it is an image based question and there is A, B, C, D all marked, but they are asking about the nerve supply for the pinna. So there are combination of the nerves given and we have to choose the right answer. So I would like to describe the nerve supply, but before that I could take this similar image and tell you about the nerves being marked. So this was exactly the image which has been asked, and here clearly in this diagram we can see the A area, that is more lateral aspect. So here we can see the A area is corresponding to great auricular nerve. If I talk about the E area, that is lying more superiorly close to the occiput. So this is lesser occipital. So here we have, we have to go with I think A, B, C, D has been asked only. So I will go with A, B, C, D. And here B area is auriculotemporal nerve. B, auriculotemporal nerve being the branch of mandibular division of trigeminal nerve. C area is supplied by the branch of facial and vagus, and also the D area is having innervation via facial and the vagus nerve. So this is overall innervation which has been tallied with this image, and this is all about the nerve supply. So definitely the correct answer will be C, great auricular, auriculotemporal, vagus and facial. Now, if I talk about the sensory innervation of the external ear, they are the branches of trigeminal nerve along with facial and the vagus nerve, and also the lesser occipital nerve, the great auricular nerve are the spinal component. That means these are the nerves which is giving innervation. We have got great auricular nerve, we have got lesser occipital nerve, we have got the branches of trigeminal, facial and the vagus nerve. So exactly this is another image where you can see the innervation of the concha receives from the auricular branch of vagus and great auricular nerve. So this is the auricular branch of vagus and we have got the great auricular nerve, auricular branch of and the great auricular nerve. So all these, and also if you will see the lesser occipital nerve. So beyond the concha we have got greater part of pinna being innervated by auriculotemporal. You can see the dorsal aspect also where we have got the dorsally superior aspect auriculotemporal nerve innervation is there. Also via lesser occipital nerve and superior to concha and by the greater auricular. So in short we can see these are the important nerves: great auricular, auriculotemporal nerve, branch of vagus, the lesser occipital nerve, which are giving innervation to the greater part of the pinna. Now here if I talk about lateral aspect of tympanic membrane, exactly tympanic membrane, eardrum, which is not shown in this image, but greater lateral aspect of tympanic membrane, external auditory canal, external auditory meatus, all are innervated by the branch of facial nerve, nervus intermedius, the auriculotemporal nerve and auricular branch of vagus. It's also important that you should know the concept of nervus intermedius. When I am using the term nervus intermedius, it means the sensory component of facial nerve. Actually, when you will see the ventral aspect of the brainstem at the pontomedullary junction, the nerves are emerging out. So, at the pontomedullary junction, as you proceed from medial to lateral, the nerves emerging are abducen nerve, the sixth cranial nerve. Then we have got the motor part of facial nerve, then we have got the nervus intermedius, and then we have got the vestibulocochlear nerve. So exactly we will see the nervus intermedius, the sensory component of facial nerve, sandwiched between the vestibulocochlear, the 8th cranial nerve, and the motor division, motor part of the facial nerve. So it is called as nervus intermedius. Now let's come up with some of the direct MCQs being asked. So after ovulation, these are the questions which also we must has been explained in the gynae and obs. After ovulation, the egg is in which state? Secondary oocyte arrested in meiosis second, secondary oocyte arrested in meiosis first, primary oocyte arrested in meiosis first. So following options are there. Actually, you should quickly revise the oogenesis process. Okay. So we have to see, actually we know that oogenesis process has been started before birth, and you have to know the sequence of oogenesis, and the correct answer is after ovulation, the secondary oocyte is arrested in meiosis second. Okay, now I just want you to show these are primordial germ cell. Okay, they by mitosis oogonium is formed. Then what happens? They enter, the primary oocyte enters the first meiotic division. But it is very important for you to know that the first meiotic division is not completed until before ovulation occurs. Okay, so that is clear that oogenesis has been started before birth and the process going, but there is a oocyte maturation inhibitor factors, and till puberty, you can say exactly before ovulation, the prophase first meiosis is arrested. So this is it enters in the prophase of first meiotic division, but the first meiotic division is completed just before ovulation or with ovulation. Then we have got the secondary oocyte form, and primary to secondary oocyte will occur by a first meiotic division, which is a reductional division, and the number of chromosome is from diploid, it has become haploid. Now the second meiotic division occurs, and the second meiotic division, the secondary oocyte will again enter into the second meiotic division, but please note down, it is also, the process is not completed until the fertilization occurs. So, and when the fertilization occurs, the second polar body is released. So, definitely the right answer here will be secondary oocyte arrested in the meiosis second. Is it clear? Okay, what I have done a quick recapitulation of the process of oogenesis. Okay, so you have to know the arrest and the completion of first meiotic division, and you have to know about the completion of second meiotic division. Okay, let's move on to the next MCQ. Now, this is a question where gag reflex has been asked. Okay, gag reflex components. Okay, it's very important that important reflexes, you have to know the afferent and efferent components. So, the combination of nerves which has been given, we have got 9th cranial nerve, the 10th cranial nerve, the 10th and the 12th, 11th, 12th, 7th and 9th. So, we have to choose the most correct combination of nerve which is involved in case of gag reflex. So, the right answer will be the glossopharyngeal nerve and that of the vagus nerve. So, absence of gag reflex is the symptoms, or it's a condition where either the glossopharyngeal nerve can be involved or the vagus nerve is involved. So, exactly we will mark this as the correct answer. So, definitely 9th and 10th is the correct answer. Also, it is important that you should be knowing about the reflexes involving cranial nerve. So, we have got pupillary light reflex, and when we are talking about pupillary light reflex, the nerves being involved is second cranial nerve and the third cranial nerve, the optic nerve and the oculomotor nerve. If we talk about the accommodation reflex, where from distance to near vision, the changes occurs, the constriction of pupil, the contraction of ciliary muscle, and also the convergence of medial rectus muscle. So, here also the involvement of second and the third cranial nerve also occurs. Jaw reflex, the trigeminal nerve, corneal reflex called as blink reflex, involvement of trigeminal and that of facial nerve. So, if I talk about vestibulo-ocular reflex, actually vestibulo-ocular reflex, there is cumulative involvement of the nerves. We have got sensory and the motor component. So, here if I talk about vestibulo-ocular reflex, vestibulo-cochlear nerve is involved. Other than that, it will lead to the involvement of motor component, oculomotor nerve, the trochlear nerve and the 6th cranial nerve. That means 3rd, 4th and 6th. 3rd, 4th and 6th, these are the nerves which is giving innervation to the extra ocular muscle. And what was asked in the examination was about the gag reflex, and the right answer is gag reflex. The 9th and the 10th cranial nerve is involved. Glossopharyngeal and the vagus nerve is involved. Okay. So done with this. Now we'll move with the next MCQ, that is question number 10. Which of the following prevent polyspermy? So 4 components, actually all these steps are involved for the penetration of sperm uh, and the fertilization to take place. But I would like to explain this if I have to choose the most correct point about the prevention of polyspermy among the option provided: acrosomal reaction, cortical reaction, Jonah reaction, capacitation. I will go with cortical reaction as the best answer, cortical reaction. Now let me explain briefly about this. So actually when we are talking about cortical response, actually this cortical response is preventing polyspermia. The union of sperm, one sperm, if there is a union of several sperm with one sperm, that would lead it is a mechanism brought on by the release of cortical granules from the egg. Actually the impermeability is formed and the other sperms are not penetrated. So this has to be explained. The right answer will be cortical response. So exactly hota kya hai? The steps. What are the steps? So fusion of sperm and egg takes place and following steps are there. First steps which I want to tell you about is capacitation. So what is capacitation? The change that is sperm. So conditioning of the sperm which happens when it has to traverse in the female reproductive tract. So that is achieved and some changes will happen to achieve the capacity of penetrating and fertilization of the egg, that is called as capacitation. Now attraction of the sperm to us. So I'm just I just want to tell everybody, I'm just explaining briefly. Okay, we have already done all these in the sessions and the classes in much more detail. So I'm just giving the quick recapitulation of the question being asked. Alteration of the sperm towards the egg and then binding of the sperm with Jonah pellucida happens. So these are the steps, prerequisite steps, so that polyspermy doesn't happen. But most important step and the correct answer will be cortical reaction. Then we will come with the fourth step, the acrosomal reaction. Okay, acrosomal reaction allows the sperm to release acrosomal enzyme to penetrate the envelope around the egg. So due to acromosal reaction, what will happen? The plasma membrane of both sperm and ovum will fuse and this will result, and the resultant condition will be the sperm is entering into the ovum. After the sperm fuses with the egg, further entry. So one fusion has happened, one sperm has fused the egg, the other sperm want to reach, it has to be prevented, and this prevention is done by cortical reaction. Polyspermy, entering of more than one sperm into the egg, and this is prevented by the step that is called as cortical reaction, release of granules, cortical granules and cortical reaction, preventing polyspermy. Now the cortical reaction is the condition in which calcium dependent reaction which cortical granules present in the cytoplasm of egg is released by the exocytosis process into the perivitelline space immediately after the fertilization. And because of this, the granules harden the Jonah pellucida. After that, after this process, this cortical granules will harden the Jonah pellucida and the sperm receptors on the Jonah pellucida is lost, and this will prevent the further entry of any other sperm and prevent polyspermy. So got it? So we have already done the steps of fertilization and the steps of implantation in detail in our live session. Now we will move with the next session, next question being asked. Actually, this is again a question. Implantation occurs which day post fertilizer? Actually, we have to take a range. Okay, exactly day will not be 10, but I will pick the most closer answer. So 2 and 5 is already not the right answer. I will go with 8 as the right answer, or 8 day. Okay. So exactly it happens in a range, and it can not exactly happen in a day. It will proceed. 2-3 more days will be also required. But for the option provided, if it was the option, you should definitely go with 8th day. I will explain why. So about 6th day after the fertilization, the blastocyst will attach to the lining of the uterus near, and this process of implantation is approximately completed by 9th to 10th day. Okay. So we can say that ovulation occurs, then the fertilized egg fuses, then the cleavage happen day 2, Then we have got the 4-cell stage, modular stage. Actually, these all changes happens. How is the blastocyst cavity is formed, blastocyst form, and ultimately the implantation takes place. So that will take on 9th-10th day, and closer to it is the 8th day. So we will take 8th as the right answer. It has a range. It can happen at 7th day also. Now let's move on to the next question, that is question number 12. Fracture at which site the longitudinal growth of bone will be affected. Something like this was asked. This is a question of general anatomy, and we have already in the general anatomy session we have covered the all group of hybrid muscles. We have discussed the general anatomy of muscle, the general bones, the epiphysis, the law of epification, the sesamoid bone, and we have discussed about diaphysis, parts of long bones. We have discussed about types of epiphysis. We have discussed about all the example of joint. So here we already know that epiphyseal plate is there, and after further fusion of diaphysin and epiphysis, it will be in the form of epiphyseal line. Okay. So if there is a fracture at the site of epiphyseal plate, then the growth will be affected. Then the bone growth will be affected. So definitely we are going with epiphyseal plate as the right answer. So actually epiphyseal growth, if I talk about epiphyseal plate, it is responsible for longitudinal bone growth. Actually, there are so many quacks and all, they will tell that take this medicine and the height will increase. Doesn't happen. Why? Normally, once the epiphyseal plate has been fused and it has been transferred into epiphyseal line, further height of the individual will not happen, and actually this fusion is taking 2 years earlier in girls than boys. So an average height of females are slightly less than males. So that is the reason, because the fusion, epiphyseal plate fusion or transfer to epiphyseal line, that happens 2 years before in case of girls as compared to boys. Okay, so let's move on. So these are some direct MCQs only. I think everybody must have marked it right. Now moving to the next. So there is one image based question. Actually, it is a question of histology. And if we talk about the histology, we have already talked about histology in detail, and we have talked about the lining epitheliums also in detail. Here we have to identify the slide. So here first thing is that a hair follicle is being seen. So this is a slide of skin. Actually, we have to know what is A, what is B. So combination will be must given. This image, there must be a combination of options given, but I'm just taking this image and I just want everybody to understand this. So I'm enlarging this image. So exactly this is the hair follicle which has been. So this is exactly the hair follicle. So this is the, and this is the lining epithelium which you are seeing. This is the lining epithelium. Okay, this is the lining epithelium, stratified, squamous, keratinized epithelium. Okay, now here if you will see close, B is just attached to the hair bulb, and this structure which you are seeing, if I talk about this structure, this is attached to the hair follicle. This structure is the sebaceous gland for the oily secretion. Sebaceous gland is a type of holocrine gland. Actually, types of merocrine, holocrine, apocrine, all has been discussed in the topic of glands, and there I have also discussed about the important structures in the skin, the cells, and what is its function. So if I talk about the another cut sections which you are seeing close to it, this C point, this C structure, this is exactly the sweat glands, and this whitish structure which has not, this is all appearing like white signatoric appearance, not taking stain. This is adipose tissues, and this is the muscle which you are seeing. Okay, this is a muscle which is attached to the closer to the hair follicle. This is erector pylorum muscle. Okay, contraction of these muscle make the hair follicle straighten up. So this is, and goose skin happens. So erector pylorum. So here A is erector pylorum, B is sebaceous gland, C is sweat gland, and D is adipose tissue. Sebaceous gland is an example of holocrine secretion, holocrine type of gland. Sweat gland is an example of merocrine gland. Sweat glands all over the bodies of merocrine except the axillary region, pubic areas and all, which is of apocrine type. Done with this? So we have done with this properly. You have to identify firstly the slide. You can identify, you can see the stratification of epithelium is there. So it is stratified and deposit of keratin will be there in the skin, and it is stratified squamous keratinized epithelium with all the structures of the hair closer to hair follicles we can identify. Let's move on to the next MCQ. That is MCQ number 14. This I have several times explained in the class. Whenever I have gone for the histology session of GI tract or in the gross anatomy part also of the tongue, I have already explained the different types of papillas on the dorsum of the tongue and the characteristic feature of each type of papilla. How many papillas are there in the dorsum or part of the tongue? We have got 4 types of papilla. We have got fungiform papilla, we have got filiform, circumvallate and foliate papilla. Actually, if the question comes about the lining epithelium of the tongue, that will be stratified squamous non-keratinized epithelium. The odd man out is a filiform papilla. Why? Because I will tell you, filiform papilla lack taste bud. It is not having taste bud. So many times I have told you that filiform papilla is not having taste bud, and it is having, what does it have? Is having. So it is not having taste bud, but it is having the keratinization. So if the question comes about the lining epithelium of the tongue, the answer is stratified squamous non-keratinized epithelium. But if the question comes about filiform papilla, there is keratin deposit, but it is lacking taste bud. So in circumvallate papilla, which is the largest papilla just anterior to sulcus terminalis, there is large number of taste buds. Foliate papilla is rudimentary in case of human beings. It is rudimentary in case of human beings, and fungiform papilla is mushroom shaped, and it is also having taste bud. So we have got only the filiform papilla, which is lacking the taste bud, but it is having a keratinization, and this is why the tongue will have a gritty appearance on the dorsal aspect. Now I would like to show you an image which is showing you the dorsum of the tongue. You have to understand the anatomical, you have to understand the important features. So let's talk about that. So I just want everybody that there will be a sulcus terminalis. So here you can see here, this line is sulcus terminalis. This is the sulcus terminalis, and this line is the sulcus terminalis. Sulcus terminalis divides the whole of the tongue into anterior 2/3 part, and here we divide it into posterior 1/3 part. Now, if we talk about posterior part, it is not having papillas, it is having aggregation of lymphatic nodules, lymphatic follicles, and this aggregation of lymphatic follicles and nodules will form lingual tonsil. What we are concerned about the papillas, which has been asked in the examination. So, over the dorsum of the tongue, very small, tiny particles like a small tiny papillas are there, that is widely spread, that is filiform papilla, giving the whole tongue surface a gritty appearance and roughened appearance because of keratinization. Lacks the, it is not having taste bud. Fungiform papilla will be larger, and in between the filiform papilla slightly larger than that of filiform papilla. The vallate papilla, which is circumvallate papilla, as you can see, it is lying just anterior. It is lying just anterior to sulcus terminalis, and maximum number of taste buds is lying there. This small one which you are seeing here is the foliate papilla, which is exactly rudimentary in case of, they are not, they are having taste buds, but they are not functional in the case of human beings. They are rudimentary in nature. So exactly, this is very important for you to know the different categorization of the taste buds. You have to know. Actually, if we will see the enlarged view of circumvallate papilla, I think 2 years back also a question has been asked about circumvallate papilla. There was a histological image of the tongue, and the arrow was marked about the on the circumvallate papilla, and you have to identify which type of papilla is this. And on the lateral margin there is moat. Okay, in that lateral aspect and the lateral moat there is trench, and in that we have got the taste bud containing gustatory cells, supporting sustentacular cells, and that of the basal cells. Okay, so that is important, that you should know about the taste cells also. Now let's move on to the next question. Okay, identify the arrow marked nerve. Actually, this is a cadaveric image, and where you have to first identify the nerve. So exactly, if this is image, the first thing is that how you are going to, this is the nerve. Can you see I am using different color? This so this is exactly the nerve which has been asked. For identification, let me use yellow color. You will confuse. This is the nerve, and I am just using this. This is the pectoralis minor muscle. So pectoralis minor muscle is covered and overlapped by this large muscle, which is the pectoralis major muscle. This is pectoralis major muscle. So pectoralis minor muscle is the key muscle of the axilla, which will divide the entire axillary artery into three parts. And exactly how I am, so why we will mark, as we know that medial pectoral nerve and lateral pectoral nerve. So both of these nerves are innervating both of these pectoralis major minor, and both of these are example of hybrid muscle. But if I have to choose one which is penetrating the muscle, we will go with medial pectoral nerve, because pectoralis minor has been shown in the image. So exactly the medial pectoral nerve enters the pectoralis minor muscle. It gives several branches to supply the nerve, then perforate. So exactly perforation is there, and this nerve will perforate the pectoralis minor muscle to reach the pectoralis major muscle. So actually this is very important. For example, same kind of example I want to take. If you will see the dissection image of coracobrachialis muscle, when we go for dissection also, how we are going to identify that this is musculocutaneous nerve? Actually musculocutaneous nerve, which is giving innervation to BBC, biceps brachii brachialis and coracobrachialis muscle. So that will be seen penetrating into into the coracobrachialis muscle. So here, how to identify this is medial pectoral nerve? It will be penetrating pectoralis minor muscle, and then it will perforate the pectoralis minor muscle to give innervation to pectoralis major muscle. So done with this. So that is the reason we will go with the medial pectoral nerve as the right answer. Medial pectoral nerve is a branch of medial cord of brachial plexus having the root value C8 and T1. A lateral pectoral nerve is a branch of lateral cord of brachial plexus having the root value C5, C6 and C7. Now here one more image is there. So exactly this is an image where you can see the pectoralis major muscle has been reflected and the nerves branching of the middle. So you can appreciate these nerves. These are the nerves. So these are the nerves. Actually these nerves are MPN, medial pectoral nerve, which is piercing the pectoralis minor muscle and then going towards the pectoralis major muscle. Now move to the next MCQ. Okay, identify the labeling correctly. Actually, this is a transverse section and we have to identify. Actually, I would like to show this transverse section of thorax cavity, and then I will show you the same image and with another one corresponding to it. So we have got A as an ascending aorta, B superior vena cava, C as pulmonary trunk and D as descending aorta. So I just want to let's have a look of these images together. Okay. So if you will see these images together, first thing is that how you are going to identify. This is P for posterior. Why? Because this is vertebra. This is sternum cut part. So this is A for the anterior part. Now here we can see the vertebra posteriorly, and if we will see the structure posteriorly close to it, we will have this structure as you can see in this diagram. So this will be the descending. This structure will be the descending aorta. D is the descending aorta. Got it? Then we will have this as a pulmonary. This structure which you are seeing is the pulmonary trunk. So this will be the pulmonary trunk. C, A will be the ascending aorta. A will be the ascending aorta, and just close to it we will also have D as the superior vena cava. So you have to compare these two images, which is showing you the transverse section, which is a transverse section MRI of the chest, which is exactly showing from the showing at the level of superior aspect of the thoracic vertebrae, and definitely you can appreciate the important structure visualized. So if you will compare this, so exactly I want everybody, this was the image given, you can just correlate. This was exactly the image. I just want to rub this because okay, so this was the image given, and I just want everyone to correlate this image with the image here given. Okay, as you can see here. Okay, So you can correlate with this. Okay. Now let's move on to the next, that is question number 17. The nerve passing through the arrow marked region has been lesioned. Okay. So which of the following is the clinical presentation? So exactly here cranial cavity has been shown. So we know that the cranial fossa has been shown and we can see just below. So if you will see this image, you can just let me enlarge it. So if you will see this, you can see just below the lesser wing, just below the lesser wing of sphenoid, what you can see, just below the lesser wing of sphenoid, you can see the arrow has been marked and this arrow is in the superior orbital fissure. Okay, so we are knowing that this is in the superior orbital fissure and now we have to mark the right answer. Okay, so we have to know whether loss of sensation of nasopharynx mucosa, loss of sensation of middle part of the face, maxillary region, loss of jaw area or loss of sensation of scalp and nose. So I will go with loss of sensation of scalp and nose. I will tell you why, because the reason is that this is superior orbital fissure and we know the branches of ophthalmic nerve traverses through it and that is compressed in this condition. So exactly, I just want you to see the same kind of image and you will have this image here. In this is an image of cranial cavity which you are seeing, the cranial fossa. So this is superior orbital fissure, this is foramen ovale. So the green color structure is superior orbital fissure and we have got a foramen here and this is exactly the arrow mark. So we are now knowing the structure is superior orbital fissure. Now we know that so many structures passes from superior orbital fissure. We can divide this whole structure superior orbital fissure into three areas. Okay, so we have got LFT, lacrimal frontal trochlea. We have got the middle area through which the through division of oculomotor nerve, nasociliary abduction, and we have got inferior ophthalmic vein traversing below. So all the structures which is traversing from this foramen has been shown. So exactly now it is known that frontal, lacrimal, nasociliary, these are the three important nerves which is traversing through it, and we have to know this. We also know the trigeminal nerve has got three components, three divisions: ophthalmic, maxillary, mandibular. Ophthalmic branches traverse through superior orbital fissure, maxillary traverse through foramen rotundum, mandibular nerve traverse through foramen ovale. Now, ophthalmic division passes through superior orbital fissure, the maxillary division passes through foramen rotundum, and mandibular division passes through foramen ovale. Now, if I talk about the frontal nerve, it can be seen forming two terminal branches. We have got frontal nerve is having two branches, supraorbital and supratrochlear. The nerve exits through the orbit anteriorly and provides sensation. If we talk about these two nerves, these are giving sensation to upper eyelid, forehead and scalp. So only we have marked scalp and the nose as the right answer. The reason is that two other branches, nasociliary is providing innervation to the areas of eye, conjunctiva, ethmoidal ear sinus and also the nasal cavity. The other frontal is providing innervation to upper eye, lid, forehead and frontal ear sinus. The lacrimal is giving innervation to the upper part of the upper eyelid. It is also giving innervation to the conjunctiva, lateral fornix of upper eyelid, and also it is giving innervation to the lateral forehead and scalp. So such a brief discussion of all the branches and identification of foramen. If I have to choose the best answer, I will go with the right answer, loss of lesion, sensation of scalp and nose. So we'll go with loss of sensation of scalp and nose. Let's move on to the next MCQ. What is the diagnosis of the case? So here the bladder extrophy, Omal Seal, umbilical hernia, gastroenteritis. Actually these all are already explained, can be ruled out. The right answer is bladder extrophy. So we can see the skin covering and the anterior part of the bladder is missing. This is a case of bladder extrophy. So here you can see, if we talk about the ectopia vesicae, bladder extrophy, in this condition what happens? There is a in this condition, the median anterior abdominal wall and anterior wall of urinary bladder is absent. The mucosal surface of the posterior aspect of bladder showing the ureteric orifice is exposed. So there will be having dribbling of urine from the ureteric orifice, and the reason is lack of migration of mesoderm in the lateral folding of the embryo, and that is leading to the case of extrophy of bladder. Now this is a line diagram and this is a same kind of diagram which was given in the question, clinical picture which is showing you that the mucosa of posterior urinary bladder is exposed. So definitely this is a condition of extrophy of bladder. behind medial malleolus and in front of Achilles tendon, which artery is palpated? The option is posterior tibial artery, peroneal anterior tibial dorsalis pedis artery. So my dear aspirants, actually my dear students, definitely I think this question has been asked in previous year of FMGE exam also, and has been asked in the case of NEET-PG exam. So only it is important that you should solve the MCQs of NEET-PG, INI-CET and FMGE exam. All questions are from these topics only. They are intermixed in different exams. The correct answer is posterior tibial artery. So exactly, the posterior tibial artery is palpated just behind below malleolus ankle bone, and it is we can find the pulsation by two fingers being between the medial malleolus Achilles tendon. So moderate pressure is required to feel the posterior tibial pulse. Here we are palpating, as you can see, posterior to medial malleolus, we have got the pulsation of posterior tibial artery. Now, which nerve supplies a hybrid muscle? Actually, in general anatomy session, I have given you all the list of hybrid muscle, but the question is spared in sciatica and tender hamstring muscle. Actually, if I talk about hamstring muscle, in the hamstring group, we have got two kind of a muscle, which is the hybrid muscle. We have got the adductor magnus, which is having both component as the component of adductor compartment and hamstring part. So if adductor magnus is the largest and the bulkiest muscle, and it is having dual nerve supply, it is innervated by the tibial component of sciatic nerve. It is also innervated by the obturator nerve. So we'll go with obturator nerve as the right answer. Actually, the other muscle is biceps femoris, which is also a hybrid muscle innervated by the common peroneal and tibial component. Okay. Now, most common site of congenital diaphragmatic hernia. So I will go with posterolateral. We have got Morgagni and we have got Bordelac hernia. So we will go with this. So here you can see there is anteriorly there is Morgagni hernia, and posterolaterally in the gap in the pleuroperitoneal membrane we have got Bordelac hernia, which is most of the time located in the left side and posterolaterally. So we'll mark this as the right answer. So I'm going quickly. Okay. So the patient actually in this condition also full question has been not given, and option is not clearly written because we have got two muscles as a hamstring group. We have got biceps femoris and also the adductor magnus group. So I will choose with the adductor magnus because both can be part of it can be spared. Now a patient with loss of sensation on the lateral 3.5 fingers, thenar atrophy and the nerve being involved. So definitely the right answer will be median nerve, which is giving innervation to lateral 3.5 and also giving innervation to thenar muscle. Now moving to the OK sign. So more questions, OK sign, some question was asked about exactly the framing of question is not known with the options, but OK sign is due to the injury of anterior introitus. So actually these are the anatomy MCQs which we have targeted and explained. Hope the session is useful for you. I will meet again with the next session, and all the questions, if you go through the notes and if you go through all the sessions which we have already completed, the questions are being asked, and the trend is actually the intermingling questions of the INI-CET, NEET-PG and FMGE examination is done. So I feel that you should definitely revise it because few questions are directly repeated and it's not very tough. Okay. So directly anatomy is questions is many of the students were telling directly anatomy ke question I nahi the 3-4 only, but if you will see the questions of orthopedics, if you will see the questions of optha, eye, gynae, op surgery, they are all anatomy based, and this is integrated questions being asked. All the best and keep studying. We'll meet again with the new sessions with an explanation of all the important questions being asked. Thank you.